Very much indeed. Again, you're beginning to get a pattern of consistency, some differences, but striving always in these guidelines to produce guidance for the doctor, guidance for the patient, and guidance coming for the referring physician. So I'm delighted that Professor Ardill and Dr. Bascom are doing a joint presentation. So Professor Ardill first, thank you. UK NETs, UK INETs.
It's always a little bit difficult coming as the last person of four because, in fact, as you will see, the guidelines from all the different areas are rather similar. I'm going to take a slightly different approach and probably start off where Walter ended up. And I'm going to give you a little bit of history and background to why we developed guidelines in the UK. Now, in Europe, we have many countries. In the US, you have many states. And in Canada, you're very, very widespread. But in the UK, we're quite a little country, and we have a health service, a national health service, which provides free treatment for all. So we could work together on that basis. So it was a health service-based group. It was founded by Martin Kaplan, who's a relatively young physician, a gastroenterologist in the Royal Free Hospital in London. And he had this vision that it would be excellent to bring together all the expertise that there was peppered about the country and try and get some consensus for management of patients with neuroendocrine tumours. You know, these tumours are quite rare, and there were half a dozen people or maybe 10 groups in the UK where there was quite significant expertise, sometimes in the medical field, sometimes in the surgical field, sometimes in the laboratory field. And there were centres where patients could have an advantage because they lived in that area. And there were other areas where patients were just totally neglected because nobody was interested. And people would see one patient in a lifetime, and that doesn't give a very good standard of care and standard of experience. So Martin brought together to London to a hotel for a day, probably once in 2 months initially, those that were interested from throughout the UK, 2 from each centre, so that we could have a multidisciplinary approach from square one. Because as you've heard many, many times through this meeting, and there's been huge emphasis that you're not cared for by a surgeon alone, you're not cared for by a pathologist alone, or an interventional radiologist. You need a team all working together and deciding what is the best approach for you as an individual patient. So we met regularly in London, and we had 2 representatives from each group, and that included physicians. A lot of you have presented with GI symptoms and gone to what we call a gastroenterologist, and I'm not sure what you call that in Canada, or an endocrinologist, medical oncologist because your tumour has progressed a bit and you've had a bit of liver disease and that has been noticed, and so you've been referred to an oncologist, nuclear physicians, radiologists, so the interventional people and the diagnostic people, surgeons, because they're very key, because as you've heard many times also in this meeting, surgery is the option that gives you a potential cure. Pathologists, because we need to know, as Sue Odorizio was saying, details, a lot of details about your tumour. Clinical scientists, because we look at your blood, and the physics people will prepare some of the materials that are used for radiation therapy. And specialist nurses, who are very important, who look after you on a day-to-day basis, and you can contact frequently. And all of our centres would have a specialist nurse. So there was immediate encouragement for communication between the groups, sharing of knowledge and sharing of experience, taking the best aspects from every group and focusing on improving the pathway for patients, for patient diagnosis, for patient management, and for patient care throughout. And it was inclusive rather than exclusive. We didn't decide as a group, right, we have the best knowledge, so we don't want anybody else to join us. We encouraged people to come in and join the group and start a group in maybe an area of the country where there wasn't a lot of expertise and patients were being neglected, and constantly multidisciplinary. So after we talked for about 2 years and shared ideas and started to add in practices within the different groups, in Belfast we were maybe not doing certain things, so we began to include those in our care, the new ideas from other groups. And likewise in other centres, ideas would come maybe from us to them. So it was sharing experience, sharing ideas. And after about 2 years, so about 2002, we decided to write guidelines. And you've heard that this is a long and arduous process. So we prepared guidelines with a focus on what was available in the UK. It's no point in saying that we would like to do this, we would like to do that, if that is not available. If it was available in one centre, that would be included in the guidelines. It took us 2 years to write the guidelines, so that took us to 2004. And it took us 2 more years to publish the guidelines. So they were published in 2006. And in 2006, they were immediately out of date, which is a problem with publishing guidelines. Now, this is just a map of the UK. So up in the north, on the right-hand side, there is Scotland. Wales sort of sits out towards Ireland. England is the majority of the country, and then Ireland is over to the side. So we started off with 10 groups, I think, 4 of which were in London, where the very big population is. A couple in the Midlands, where there's also a population north of London. And then scattered throughout the country. That has increased, and I think we have at least 17 groups now. And we meet probably 3 times a year, and we have quite a lot of teleconferences. So we still work together very much as a group, working together, advancing care, and working on from those first guidelines. So the first guidelines were published in a journal called Gut, and these are available, and they're very out of date. So don't be going using this as a textbook just right now. Martin Kaplan was the initiator of the UKNet group, which was a group of specialists. That has developed into a society, and we have had meetings right from 2002 onwards, scientific meetings, where we've asked people to come and speak on their research and more developments, and trying to update our knowledge all the time of what is the best way forward for you as patients. John Ramage from the Basingstoke Hospital south of London was in charge of pulling together the guidelines, and the guidelines were written by experts within each section. But as I say, these were out of date quite quickly, and we have very recently been writing the guidelines again. In 2006 we had a literature search, because we don't want the guidelines, and nobody else who has talked about guidelines this morning wants the guidelines to be our ideas of what is best. We want some evidence for it. And in rare diseases, evidence is hard to come by. If patients are suffering from diseases that are quite rare and uncommon, it's hard to find a group of 200 patients and randomize them, one to get a treatment, half of the group to get a treatment, one half not to, especially when we're not pulling together as a whole country or pulling together as a whole area, a continent, or even worldwide. So we're beginning to see trials coming through now, but at that stage evidence base was very poor in 2006 or 2004 when we wrote these. So there's a section on the etiology, what we know about why these tumours happen, the epidemiology, how common they are, and if that's getting a bit more than it used to be, in genetics, about if you're inheriting it from family to family, from parent to child. We did clinical features, so how different syndromes all present differently, and you know how diverse they are. And diagnosis, the 3 mainstays of diagnosis, which is diagnosis in the blood and urine, diagnosis through radiology, and diagnosis through the pathology specimen that comes either from a biopsy or from surgical, and treatment, and many, many different treatment approaches. And as I say, this has become quite out of date. Now, we have just had a meeting back a year ago exactly. We spent 2 days working a little bit in advance and producing new guidelines. About 25 people worked together for this, and we have these have gone for final correction by the 1st of May this year, so they will be published in Gut quite soon. And our aim was to update the previous guidelines, to bring them right up to date and try and get these published much more quickly. So we have an agreement that they will be published as soon as they have been finally edited. And to inform of key decisions for management, and we had the guideline conference back in May last year. And the sections were written by the different specialists, as I say, and the advantages in management, more specific diagnosis, improved treatment, and new randomised trials, taking all of that into account. and also assessing the level of evidence. We can say, I can say from my experience, because I've been working in the lab for 40 years, what I know in the lab, but that's hearsay. It has to be evidence-based. We have to have good research published, and we have to have trials published, and a very strong multidisciplinary approach. That has always been very key to the UK and Irish guidelines, because recently we joined with the Republic of Ireland, and we have representatives there and one centre of excellence there. So the UK guidelines are in preparation. They have gone for final editing. The cut-off day was the 1st of May, so they should be finally edited by now, and they should appear in the next few months. And those will be online. And the website for the UKNet is www.ukinet.org.uk. And those guidelines will come there. You'll also get them directly through the journal Gut, which you can also find on the website, on the internet. So we've been looking at evidence base for investigation, treatment and follow-up of patients. Now, rather than invent the wheel again, oh, John's going to come and help me. I thought he'd opted out. We're going to go through 2 algorithms. That is maybe a quicker way of updating, since we're fourth on the podium.
I won't spend too long on these, because obviously they're fairly similar to other guidelines, but this is just 2 algorithms that are part of the new guidelines. These, I have to say, are in press. Well, not in press. They're still, my understanding from John Ramage, who's actually the person in charge of writing, is that there may be some minor changes to these. So they will be finally out on the UKINet's website in the next couple of months. As you can see, it's very similar to all the other guidelines that we've seen in terms of how we investigate patients. The only difference is, of course, we can add some of the newer technologies available to us, such as gallium-68 data-tape PET, and then we have, along the bottom, additional investigations for specific neuroendocrine types depending on site and tumour type. For example, with pancreatic tumours, we're quite keen that before surgery they have endoscopic ultrasound. Again, we have discussed this before. The second algorithm is for treatment, and you may have remembered that yesterday I showed you an algorithm for treatment at the Royal Free Hospital. Some strange way, this looks almost remarkably like that, except that this one has square boxes and the Royal Free one has round boxes. And this is basically Martin's algorithm that was put on the back of an envelope in around about 1997, and I think has been the basis of most practice in the UK since then, with some minor modifications. But you can see basically it covers most of the GP neuroendocrine tumours, and again the role is, if you can cure, you do. If there's a tumour which is residual but not progressive, we don't treat. Can I just say that can be quite difficult? I don't think we've ever discussed this in the last 3 days. A significant proportion of patients with neuroendocrine tumours, where the tumour is not progressive and not causing a problem, we don't treat. And I think sometimes it can be a bit difficult to think, well, what do I do? It's there, it's a problem. But sometimes it's best just to leave tumours alone. And many patients may go decades without needing any particular treatment. So it might seem that we're being a bit lazy, but it may just that we're being a bit wise. So not treating, in fact, of our 1,600 patients in our clinic, about 500 patients are just in the observation group. Okay, they're not having any particular treatment. So not treatment doesn't mean to say we're not doing anything, it's just what's appropriate for you. All right? And I think we haven't had a session on not treatment. Maybe we should next time have a session on who do we not treat and why do we not treat. If there's progressive disease or symptoms, obviously then we would consider the analogues, and then maybe one of the new drug trials such as the mTOR inhibitors. Depending on uptake, we will use the radionuclide therapies or chemotherapy or debulking surgery, etc. And where there is hepatic disease predominant, then we may use some of the local treatments that we've discussed yesterday, chemoembolization, even up to liver transplant hasn't been discussed, or things like RFA. So that's just a simple technique, but it is very similar to I think we've seen all the way through. So the UKI guidelines aren't trying to contradict the other guidelines, they're just trying to convert that into one that works within our health system. Thank you. There's the conclusion.
John, thank you very much.